Okay. Then, David, you're good to go.
What we're going to try to talk about very, very briefly is to sort of talk about, this isn't the right way to start our World Diabetes Day chat, but we are going to talk about trying to create maybe three kind of a common language not in medicine, not in prevention, but in surgery in this case. And I'll try to put together maybe three intersecting rings of risk, talking about a unified surgical approach. You're going to hear after me so many great talks about how important this problem is, meaning diabetes and the lower extremity complications of diabetes. You don't need me to tell you that. But what I will talk to you about is kind of speaking maybe a common language worldwide, not just for wounds, not just for ischemia, not just for foot infection, but all three in three rings. And we're going to talk about Wi-Fi and kind of your Wi-Fi settings, and then a surgical philosophy focused on these. And then we'll talk briefly about the foot in remission. And then thankfully for you, we will close. And by the way, let me just tell you that we give away all of our slides. So if you want any of these, just email me or ping at me. And we just ask you to copy them and make them better and pay it forward. How does that sound? But the point when we're dealing with this very big problem now worldwide as a family is that our patients before us are just like we are. You know, we're always changing. This is a fundamental philosophy in general, and nothing is static. The foot is changing, the wound is changing, the ischemia is changing, elements of infection may come and they may go. But you have to ask now, when you're dealing with these patients in a common language, what's the dominant problem? And that's really what has led us to this common language that we call Wi-Fi, which is really simple. It's just like TNM for cancer. It's just wound, so tissue loss, ischemia, and foot infection. Very simple. And for each of these, it's so simple. You just ask none, mild, moderate, and severe. So you can just communicate each one of these. And so when you're dealing with a patient in the clinic, on the hospital wards, even in their own home or by video, you can ask, what is the dominant problem? Is it just tissue loss? Is it an ischemic problem? Or is there an acute kind of on chronic infection on top of that? And for each one of these, as I said, it's just none, mild, moderate, severe for wounds, none, mild, moderate, severe for ischemia, and similarly for infection. These are the Infectious Disease Society of America and International Working Group guidelines. And this has been validated now in tens of thousands of patients now already. First, let's talk very briefly about wound and wound closure surgery. You know, if we're talking about someone with neuropathy, there's really only two kind of factors or two pieces to the equation that we have to deal with, that we can deal with surgically and medically. One is pressure, and we can manipulate that externally through shoes, insoles, casting. And we can also manipulate activity. We used to not be able to measure activity very well, but we can now, even in developed and developing countries now. Many people have smartphones. This is getting less and less expensive, where we can dose activity like we dose a drug. But it's really an imbalance between pressure and activity that leads to these diabetic foot ulcers. And our goal is to bring this imbalance into balance. And we can do that medically, mechanically, surgically, et cetera. And there are really two flavors of diabetic foot surgery for wounds. There's wound closure surgery and there's reconstructive foot surgery. I'll just show you this brief example of kind of a reconstructive foot surgery. This is a very common transmetatarsal amputation, but the patient is in a varus kind of deformed attitude. Why don't we then simply take the anterior tibial tendon and move it over from medial to lateral, so it's not pushing in such a deforming force. And then that patient now can go on toward healing. And you see one of my fellows and now my partner, Tanzim Khan, doing this on one of our patients. And you see a foot now, it used to be slightly deformed, is less so. And now this guy, he's a great guy, part of our family, if you will. He could take more steps before his foot breaks down. This is the idea here. What about wound closure surgery? We have to move away from wound care worldwide toward getting these wounds closed and getting these patients into remission. I'll just show you here. there are people talk about the fact that you can't skin graft people with diabetes. We don't believe that's true. We believe the data suggest otherwise. And you see this gentleman who has a leg ulcer after shooting himself, unfortunately, in his leg and having a fasciotomy. We vac it and we put a skin graft on there, and you see it shrink down over months. Should be conceptually not very much different than this patient who has a guillotine TMA after an infection. And you see the skin graft being put on there, and you see this now at several months postoperatively moving out into remission. This can be very durable in a good pair of shoes with minimal manipulation there. And the same thing here, even on the bottom of the foot, this gentleman who maybe should have gotten a transmetatarsal amputation after this ray resection, but has this significant infection here and some tissue loss. After the tissue loss, you see most of this foot is not weight bearing, especially after we do a pan-metatarsal head resection. And so this foot can take quite a few steps before breaking down as well. So theoretically, a split thickness skin graft should not be all that forbidden in these patients. And if you look, most of these patients have complete incorporation, even these very sick patients, and the ones that don't, that require revision, almost all of those patients are very sick. They're on renal replacement, as you'll see here. So the key here is that even if you're failing with a skin graft, usually you're failing surgically forward. And then you can also look here very briefly at, instead of a skin graft, maybe we can do a flap. This is a gentleman with a fungal infection with diabetes in his heel. Instead of being offered an above knee amputation, we just did a partial calcanectomy. It's very, very minor partial calcanectomy. And instead of doing a skin graft, which we could have done here, one of my partners, Keaton Patel, just took a superficial circumflex iliac pedicle flap from the groin. This is a very thin, not very vascularly demanding flap. And then you see here putting it into the heel at a beautiful looking heel now at about 120 days post-operatively. So this could be a possibility as well. So that's wound surgery. But then briefly, what about surgery for ischemia? We can really fly through this. But this is very, very important. Now, especially after this last Monday's data from the BEST CLI trial, you understand now that we can take patients who have very severe infection and with a good quality vascular surgeon and interventionalist in our team effect change. You see this woman on her other side, she has a below knee amputation, and she refused an amputation on this leg. All she wanted to do was to be able to dance at her granddaughter's quinceañera before she died. This was her big goal in life, and she wanted to do it at least on one leg. She had a BK on the other side, and you see this foot, it almost looks cadaveric, and I wouldn't fault someone for wanting to do an amputation on this side, but my partner at this time, this was Joe Mills that did this. You see a kind of a ratty looking angiogram, and you see then moving toward one where you can see one vessel run off, and that you see two beautiful plantar vessels here. We can now move toward, instead of xeriscaping on this patient, landscaping. And then you see moving with just slowly, sequentially, a skin graft distally, and then skin grafts on the rest of the leg. And you see her here in clinic with us, wanting to dance. She has a BK on this side and just the TMA on this side. And you'll see her dancing in the hallway here.
That's great. At the end of the summer, we need to do a slow salsa.
Yeah. Oh, this is awesome. And look at the nurse. The nurse is freaking out that she thinks she's going to fall in the hallway. But listen, the learning point here, these are like, this could be any one of our patients. This is like our family. It could be anywhere in the world. All of these patients, they're like part of our family, and they just need something. Many just need one thing. This woman is so hard to kill. She sent me a birthday card. A Christmas card every Christmas. She just passed away, but she was able to go to her granddaughter's quinceañera. And that's what we have to offer for all of our patients. There's just so much that we can do to affect change. We don't have time to get into infection, but let me just tell you very briefly, you can see this patient with a dorsal space infection, as well as a little bit of ischemia after doing a good quality debridement up the dorsal leg. I can now have my partner in vascular surgery. Look at this. He's a huge man. Greg McGee. I think he's about 10 feet tall. And then after an angioplasty, you'll see we're just doing a VAC and a skin graft. And then this patient moving on towards healing into remission. And there's so many opportunities here to affect change. Just briefly, we can talk now not about diabetic foot ulcers, but really about their recurrence, because the learning point here for all of our patients is that nothing ruins a good surgical result like follow-up. And either the patient is going to fail or the procedure is going to fail. And the humble thing is to understand that that's going to happen. And why can't we work with our patients to maybe touch them up over their lifetime, either vascularly when they're in remission or surgically through podiatric surgery? You know that at 1 year, about 40% of these patients are going to have recurrence. It's about 2/3 at 3 years, 3/4 at 5. So recurrence in this population is humbling. It's not only common, it's likely. So if the foot in diabetes, and you'll hear this as well many times, is a little like cancer in terms of its morbidity, its mortality, then maybe when people are healed, maybe they're not healed, maybe they're in remission. And the big idea here is that by helping these patients medically, surgically, mechanically, we can help them move through the world a little bit better. And ladies and gentlemen, that is the big idea, moving together as a family, speaking a common language with our patients and collectively in our interdisciplinary teams. And here's to that. Here's to World Diabetes Day. Here's to helping people move through the world a little bit better. And thank you so much for putting this meeting on. It's just a blessing. And thank you.
Can you hear now?
Yeah,
Okay.
I could hear you. We can
Yeah,
hear
we
you
can
great.
hear you.
Yeah, one
All
question
right.
box is, what is the preventive surgeries like tenotomy? Are they useful in preventing diabetic foot ulcers?
Yeah, it's a great question. So I think many of you might know that just this last month, there was a really excellent manuscript published from our colleagues in Denmark in diabetes care that was a randomized control trial, beautifully controlled, showing just that a very simple tenotomy for distal digital ulcers can be very, very helpful in helping wounds heal and reduce recurrence. These are things that we've been doing for years and years, and now there's more of an evidence base to support them. And you can do this in your clinic with I like to do it with a 15 blade, but you can do it. Most of my colleagues and even my trainees like to do it with like a little 18 gauge needle, where you can just put a little needle in there and just kind of caress the tendon until it lengthens, and then what you'll get is a toe that goes from this to slightly more like this if it's flexible. If it's rigid, then you need to do more of a bony kind of procedure.
Thank you, David. The second question in the chat box was how useful is the infrared technology to diagnose high-risk feet? Can we predict ulcers? So you have some work on that. So.
Yeah, well, I'll tell you, a lot of this work started in India, and then ultimately came over to the United States from Professor Paul Brand, into people with leprosy. And we still treat people. We actually have the busiest leprosy clinic now, the largest leprosy clinic in the United States in Los Angeles at our clinic. Every Wednesday we run it. And we still use thermometry on those patients too, with Maria Teresa Ochoa, my partner in dermatology. But we have been using thermometry for as long as I've been training even as a resident. But we have our patients, they can purchase a device on Amazon now, and that costs now about less than $10 US delivered. And a patient can then dose their activity by checking their skin temperature, just as they might dose their insulin on World Diabetes Day by checking their blood glucose. This is the idea. Insulin, activity, thermometry, to use that to measure the subtlety differences in skin temperature. We also, and if you go onto the blog, we have our blog, and we actually have our Rancho Los Amigos guidelines for how active to get based on your thermometry, and you can log your activity if you're able to do that, or you can just estimate it. And there's any number of ways to do it. But the analogy between activity and blood glucose and insulin is actually quite a good one, and it works. And I think the data now are pretty strong now, at least as strong as anything else we're doing. People don't do it, just like people haven't done things for blood glucose early on in the 80s and 90s, just because it takes a long time to adopt anything. But I think people are getting more common to use this kind of thing, and there's many more technologies now that are even better than that can be useful.
Thank you, David. I think we have many regional chairs and board members who have joined. Do you have any question, or I'll ask the RX events to post any question from the audience in the chat box. In the meanwhile, if the board members or regional council members having any question? Yes, it-
David. Yeah, this
Yeah.
is Milind Ruke from Mumbai.
Oh, Milind, it's good. It's good to see you. It really is.
So very nice lecture. But I was
You have very low standards in my case, Milind, again, but not in your case usually.
no, you have been using a lot of skin grafts on the plantar aspect of the foot.
Yeah,
So is there any other alternative? You have been starting using dermis.
absolutely. Yes, there are. Of course, you can use, we like to use, we just like to get the wound closed as rapidly as possible. And if you'll notice the cases, I think I showed one, which had a fair amount of skin loss on the bottom, but most of that plantar foot that we skin grafted was non-weight bearing. And the part that was weight bearing, we just took out some of the metatarsal heads to allow it to transition to having non-skin grafted skin. So you can do it on the bottom of the foot, but there are definitely biologics that can be used. There is of course, moving skin around on the bottom of the foot just by rotating flaps, using free tissue transfer if you need to, or just letting the thing heal in secondarily. But we just like, philosophically, Milind, to try to get to closure. We don't call it wound care really anymore. We call it wound closure. And you need to nurse a wound, but you also need to doctor a wound. And both are really important. And when you have the people together working together to try to get the thing closed and into remission, then you could deal with an area that may be recurring or something. But now you're moving forward. You're not just sitting there in like in a, I don't know, purgatory. More paradiso, not purgatorio. We don't have any Italiani on the line right now, but there you are. Maybe more Dante rather than Frederick Banting.
David, one from the chat box. Yeah, Milind, you
Up.
have.
Yeah, and do you do the tendo-Achilles release or gastroc release at the same sitting, or you do it later?
Oh, these are great questions. So yes, so we tend to do it depends, but we tend to wait until the wound is healed before we do our tendon balancing. I think I showed one example of an anterior tibial transfer. We commonly will do that and an Achilles tendon lengthening. I'm kind of moving my body to show a foot kind of moving in space, but we'll do often both of those in the same sitting. Sometimes we won't need to do a transfer of the anterior tib. Sometimes we just do a little lengthening of the anterior tib, a Z lengthening, or even a tenotomy of the anterior tib, and then have it sit down, and then just put it into an AFO, an ankle foot orthosis, just so it can sit and sort of fibrose down into that position. And you'd be amazed 6 months later, even patients that you have done an Achilles tenotomy will often have, I know you know this, will sometimes have strength in their Achilles 6 months later.
Right.
And it's amazing, despite what we do sometimes to our patients, how plastic they are. If we could just get them into a good position and moving, and it just depends on the patient's activity level, kind of what you'd be doing. And I know Jose Luis deals with this all of the time, and he's a world-renowned podiatric surgeon and is thinking about this as well a great deal. I look forward to hearing what he would talk about as well, and he's reported on his outcomes. So there you are.
Thank you, David.
Jose Luis, yeah. So would you like to offer any comments on the tendoaculus lengthening?
Can I have a question?
Yeah, Zahid. Jose Luis will
Ah.
answer about
Yeah,
tendoaculus.
I think it's,
Yeah,
I don't know if he's going to start to speak.
Just 1 minute, Zahid. Your internet is not very clear.
Yeah.
So Jose Luis is answering a question.
Yeah, absolutely. So indeed, I think that this procedure is not very well implementing among the world. I think it's very useful. But as David told before, I think in my experience, I prefer to wait until what is the balance of the patient after the procedure. So at least 2-3 months after the transmetatarsal amputation, I think it's a good time to re-evaluate the patient, evaluate the gait, and consider what to do, because it's important. Don't forget that this kind of procedures can impact in the balance of the patient, and this can produce some gait disorder, and indeed it could be it could put the patient in risk again. So, but absolutely agree that this is a very good procedure sometimes.
Thanks, Jose Luis. Zahid, you were asking something? Zahid? His internet is not okay. So while his internet is coming back, I would like to introduce Christine Van Acker, not introduce. I would like to welcome Christine Van Acker, who got the award in DFCon. She is a founder president of DFood.
Dear friends, dear president, dear board members, in the first place, thank you for inviting me on your campaign that you are doing for the whole week for this quite important topic. You asked me to have some ideas about making an impact as a diabetic foot warrior. Why being a Diabetic Foot International member? First of all, you can't do it alone. We need each other. For myself, I was stimulated by international members and believers. I started my career as a diabetic foot soldier, warrior, clinician in 1987, and I became more active on an international level in 1991. DFood International was born in 2017 after several years being IDF Consultancy Group president and responsible from 2013 in the International Working Group of Implementation. I have to remember the history. Stefan Mulma, Neil, Abbas, Shigeo, Munia, who passed away, and Alini from several parts of the world did this important take-off. The mission of DFood International was and still is ending avoidable lower limb amputations due to diabetes worldwide. We may not forget that every 20 seconds someone loses a limb due to diabetes globally. So yes, we have to like, yes, we have to share, yes, we have to treat to help create a social change. The problem is huge, and we are aware. Foot ulcers are common, serious, and costly complication of diabetes, proceeding 84% of lower extremity amputations in diabetic patients and increasing the risk of death by 2.4-fold over diabetic patients without ulcers. We may not forget, as we look to this lady, that the quality of life is so totally different once you have an ulcer and absolutely when you have an amputation. So there is reason why we are fighting for why we have to have the diabetic foot on the agenda. The problem is situated on different levels. We need prevention, care, secondary prevention, and we all understood, especially after the publication of 87 from Mike Edmonds, that we need an interdisciplinary approach. And we have golden standards. Let's be so proud that under the lead of Karel Bakker In 96, we have had already several editions over the years about, first of all, the guidelines and later the guidance document. And the good news is that we have soon a new edition. Thank you so much for all those people who are here presented who work today to prepare our new guidance document. When we have our golden standards, our guidelines, our guidance document, we need translations, and that is done in so many languages. But even more important, we need we need an adaptation of the document to local situation and culture. And this probably was one of my love over my years of guidance and international work. It was Karel Bakker again with Henrik Conner who made the point when we met each other internationally that the document is one thing, but we need also an implementation. And implementation is a journey and involves the real work of people with diabetes and the care providers. So this is an important takeoff that we decided later when the guidance documents were already there. And for realizing this, as the cultures are so different, we need every single person on the globe who is caring for diabetes to be united and to put the input all together. Cultures are so different. What is true for Western people is not true for African people, is not true for other regions. So we need to be creative all together, and therefore creativity together will have a change. Just let's have a look for how we have so different footwear all over the world. So important to understand why it is so different and what are our resources and culture. If we pray that you even at home need a good offloading, but for example in Japan, shoes or whatever is not accepted in-house, we never think twice. So the Song of Love, what I really tried to disseminate was to create cascades of teams, train the foot trainer. Many peoples work together to realize in so many places all over the world and also in the poor regions. Thank you for having done this together. Recently, we know how war is so incredible. And I remember our national representative for Syria saying, Christine, all what you're doing is great, but what in our countries? And that inspired me a lot to work at that time with International Red Cross. And today, they have, based on our program of Train the Foot Trainer, a new ICRC implementation plan. Thank you for all this. Asking me, what is now a good soldier or an activist? I think we have to think in levels. When you're a starter, when you're happy and have, for reasons, no more energy than just on the level of your own clinic, implement the guidance document, teach others, work interdisciplinary, intra and extramuros. In case you can reach level 2 and you work in a region of your country, implement the guidance document, teach others, create symposia, make a team with other clinical workers and clinics of the region. And it's my case in the early years for Belgium, small country, different languages. On country level, implement the guidance document. Try to have an adapted one for your country. Try to have a national team with as many professionals and disciplines together. Work together with your patient organizations and try to involve politicians. Level 4, start small. Level 1, but think big. In one of the 7 regions of DFI, and so many people are regional representative, implement the guidance document again. Try to have meetings with your national representatives. Try to adapt according to your own cultures. Try to involve politicians and be connected for mental reasons to avoid burnout. DFOT activists on the highest level Level 5, being international active. Implement the guidance, document again, be a family, be united with other international organizations as we realized during our term. Have a clear, adapted visions because it's not the same working during COVID time or without COVID. Be connected for mental reasons. On all levels, stay humble, be united, be family, and try to do research at each level where possible. I'm so happy. It's the third term on leadership and the actual group. The board members are represented here. You are the young group of bringing those ideas out. I'm just the founder, but I feel still today that a lot of principals are present, counting on you, and thank you. So let's forget our ego, because it destroys, it hurts. Let's go. Let's come out of a frozen situation. Even COVID has harmed us. Let's have the takeoff. Let's do it further and further, generation by generation. Be together as a family. And I hope that at the end of your career, you can look back to a nice work together, realizing we can't do nothing alone. The sunset will be nice, but we need to be united. And for this last slide, I want to thank, because this was the slide of my last day of president and founder of the DFOD International. And at that time, we have had already so many diabetic foot soldiers. More to go for. Counting on you. And thank you on behalf of our patients worldwide, in all corners. Where is war? Where is poverty? Where is richness? But we are there to help the patient. Thank you. Good luck. Greetings from Belgium. Bye-bye for now.
So thank you very much, Christine. We will move forward.
Thank you. All the boards were good, by the way. Thank you.
So next we have Jose Luis Lazaro Martinez, who is our honorary president and immediate past president. Jose Luis, would you like to make your presentation? You have another presentation coming later on behalf of Urgo Medical, so that's separate.
Okay.
So this is
Yeah.
the topic given to you.
Okay. So I will try to share my screen. Okay. Can you see my screen now?
Yeah, we can.
Okay. So thank you very much, the Derby, first of all, for your kind invitation, and thanks the rest of the board for this kind invitation for joining another DFOD activity. Very happy that see that you are continuous working hard in this nice project, and congratulations for all the activity that you are doing and you did around the Diabetes Foot Awareness Week. So you asked me about to talk something philosophical. So I happy to say that it's something of my message is very close to the message coming from Christine, because we are aligning more or less in the same philosophy. So I tried to summarize my presentation in 3 topics. The first about what do we know concerning diabetic foot. The second one, what do we do, especially coming from DFOD International. At the last one, just my vision of my recommendation of what should we do. So the first one, probably everybody knows, are aware about the data. So this is the data or the figures coming for the meta-analysis and systematic review about the worldwide prevalence of diabetic foot ulcer. That is very, very different among the regions. But indeed, I think it's not the reality, because if you can see here in South America, we don't have any study coming from prevalence, and in South America they have a lot of problem with diabetic foot. But the thing is that probably we have a different realities among the world, and for this reason I think that we need to think different in different perspective when we are talking about diabetic foot. So one of the things that the people are blaming or complaining when you are going to deliver a lecture in some region, especially in Asia, in Africa, South America, is the variability in the clinical presentation. Probably in some countries in Europe or in North America, we have a different clinical presentation comparing other regions, and they are facing different patients that we are facing. And this is something very interesting to take into account, especially when we are sending recommendations coming for especially Western country literature. And this is absolutely different. Coming back for the EuroDial study, just a little data coming from this study, is the 91% of the ulcer included in this study has less than 5 centimeters square. So that are mainly a small ulcer. And you are going to another countries, and especially in South America, Asia, you can find how the people has another kind of diffuse presentation. But without any doubt, the common things that we are facing is the fatal outcomes, because fatal outcome is happening in any country among the world. First of all, major and minor amputation obviously did. This is a data summarized by David in a very, very nice paper in which they saw it, that mortality in a patient with diabetic foot ulcer, comparing, for instance, with patient with breast cancer is approximately the double. But if the patient suffers for lower limb amputation or the patient has a peripheral arterial disease, just the mortality is even 3 times comparing the average of total cancer. The amputation rate is very different among the world. And this is something that we need to ask. How is possible? For instance, this is coming for the OECD data. For instance, here, Belgium Belgium, Germany, and Israel are the top countries in the world with more lower limb amputation. And when we are coming back with what these patients mean, these countries mean, there are not especially low income countries. There are very high income countries. For instance, Germany is the power of the European Union. How is it possible that Germany has the higher rate of amputation in Europe? And when you are looking for the comparison of different rate of amputation in different countries in Europe, you can see here how Germany is the first one, but the last one is Hungary. And when we need to ask how it could be or how it would be possible that this thing is happening. So coming for another paper about the disparities of variability in minor amputation, for instance, you can see here the discrepancies between UK and Germany. This is a very similar countries, but the rate of minor amputation is quite different. And indeed, the main reason for this difference was delay referral and delay in peripheral arterial disease diagnosis. So without any doubt, I think that again, our main enemy was or is and are and will be the late referral and the misdiagnosis of peripheral arterial disease in the majority of the scenarios. Another important thing that we know, how important is multidisciplinarity. Multidisciplinarity is key. There are hundreds of papers demonstrate that with the implementation of the multidisciplinary approach in diabetic foot, you can reduce or you can decrease among or between 80 to 90% of the lower limb amputation after 3-5 years of this implementation. But the question is how is so difficult to implement in some countries? Because in some countries we are seeking again the same scenario. So there is the only one people working as a lone person with a diabetic foot patient, and this is absolutely not recommending because it's very, very difficult that only one person can approach all the complications that patient has, or especially patient with diabetic foot complication has. So this is that we know, and what do we do concerning DFoot International? So I think DFoot International implemented a very good work. So Train the Foot Trainer was founded for Christine, was the model Train the Foot Trainer program, and I think is pioneer in the education, professional education and among the world. And indeed, it is nothing comparable in any other association and in any other society and in any other country. This is very important in order to implement in the recommendation for the gold standard of care and coming for the international working group guidelines. And I think it's very, very good exercise, a very good activity for educate people. And coming back for the main referral and the late referral as the main enemy. So again, DFUT International do a very good work about to fix this late referral between especially primary care and multidisciplinary team to develop this pathway, the fastest pathway. This is very, very well implemented among different countries among the world and very useful for reduce and to decrease the impact of the lower limb amputation, especially in patients with complicated diabetic foot ulcer and in patients with severely complicated diabetic foot ulcer. This is a very good work. And some authors demonstrate the benefit of to implement the fastest pathway. For instance, this is a very nice paper coming from our friends in Italy from the group for the Luigi Cioli and Marco Maloney. They demonstrate that the early referral patients saw with an increase of number of people with ulcer healed, reduce the time to heal, with less rate of minor amputation, with less rate of major amputation, with less number of people with hospitalization and with less mortality. So again, I think it's a very, very good tool, the fastest pathway to implementing among the world to reduce the impact of DFUT for improving the patient outcome. One of the most important things that I think that we need to face in the future is the variability in patient outcomes, because it's very common. This is not very common only when we are comparing one country with other. Indeed, inside of our country, we can find a hospital with different patient outcome comparing the hospital in front of it. That is something very, very difficult to understand. And you know that the International Working Group did a very good job launching the international guidelines about the management and prevention of diabetic foot disease. This is a nice picture coming for the 2019 with the Professor Nicholas Scapper and Professor Bolton and myself, with the compromise to implement international guidelines among the world. Very hard compromise and very difficult to implement. And especially to implement what is the standard of care of diabetic foot. And especially because for many people among the world, treating diabetic foot is only local bone care, only local bone care. And where the people are starting to talk about how to treat diabetic foot ulcer, they're only talking about what kind of dressing, what kind of product or what kind of therapy, local therapy you need to do. But of course, standard care is too much. And for this reason, you need a multidisciplinary approach. But the problem is that there's a gap between the international guideline and the reality. One thing is the evidence, another thing is the daily practice, of course, one thing is recommendation, and another thing is the implementation. Implementation, hard work and very difficult. This is a huge challenge. And especially because we have different settings, different reality, different approach, and different even classification. I used to include in my presentation always this paper from David, because I think this is summarizing the most important thing when you are approaching a diabetic foot, the debridement and offloading that is coming back. This is the type of offloading, for instance, in some countries for South America. This is a picture coming from Uruguay, where a patient in the waiting room, waiting for his doctor. And this is the offloading that the patient wear. So sometimes it's not possible. What about classification? I think that we have the Babel Tower about classification, because we have more than 25 classification systems among the world. And again, every people is speaking a different language. So it's very difficult to understand when you are speaking English and another is speaking Russian, another is speaking Indian, another is speaking Japanese. And the problem is that so far we don't have an agreement, especially in some regions. For instance, in Latin America, the imposition on some classification, the people feel like the colonization of the classification, and this is not a way to implement it, absolutely, because this is producing indeed the opposite that you try to implement. So the guidelines are a hard document with 230 pages, and the problem is how to implement. So again, the food did a very good job. I think this is coming from the InfoCard. At the beginning, we were criticized for some people because the people said, "Hey, this is a simplification of the international guideline." Yes, it is, but it is something that the people need, because sometimes the people don't need time or don't need or don't want to read the recommendation. And it is a very simple way. In some vision, you can know how to screen the people, or in one view, you can know how to diagnose diabetic foot osteomyelitis. This is a good job that DFOod did. And another good thing that DFOod did is the translation in different languages. For instance, some of the InfoCard were translating for more than 15 languages. And indeed, very proof. For instance, with one of our regional chair, this is Maimouna from Senegal, and with this activity delivering the implementation of this InfoCard and some other information that we have in the web page. So that is something interesting that we did. It's very, I think that we need to feel very proud about this. Again, we did the translation for the international guidelines in several languages in order to help the people to implement it. But without any doubt, it's very important. I think the strength of DFOod is the international network. This is the strength, because you can connect in 2-3 emails with one DFOod warriors in the other part of the world. That only you have to ask to regional chair, or you have to ask the board of DFOod International to connect in someone in some place in some countries in the world, and to asking about something that you need. For instance, if you are traveling there and you need some help for knowing how the people they are working there about diabetic foot passing. So finally, my humble recommendation, of course, about what should we do. So coming back, what are with the problem? What are the main barriers for an integrated food care globally? Again, the lack of the awareness. I think that this kind of activity is very important to do, because we need to increase the awareness. But we need to increase the awareness not only in healthcare provider, indeed, also in patient and also in the society, because sometimes the society is very far for diabetic foot. Again, another barrier is the lack of global implementation. Sometimes we are missing primary care. I think primary care is very important, and perhaps we need to put more effort and more invest in primary care, because primary care is the gate when the patient entry for the national health system in many countries. So primary care again is very important. So another barrier, the poor implementation of the international recommendation. Sometimes we find or we can find different guidelines for different countries, for different associations. And sometimes I was wondering why, because there are a lot of people working for 4 years in a very hard way to having the best recommendation. But use that. You need to adapt, of course. You need to implement in your country, but you have the international recommendation. So try to implement in your reality, in your daily practice, but it's not very efficient to try to develop a new guidelines. Another important thing that we need is data. For instance, as I saw it in another slide, we don't have any data from South America. So that means that in South America there are not diabetic foot? Absolutely not. But if you need to talk with some politicians or some governments, they are asking for data. So we need data and we need epidemiology. Again, politicians. So I think the people used to say, okay, I hate politicians, I don't like politicians. Yes, but you vote and you elect, and you need to work with them. Even if you don't like, you need to work with politicians, and you need to knock his door in order to change the things. And another thing very important, the unity of diabetic foot world. This is very important. Local implementation is key. Indeed, I think it's very important to connect with the local association, to connect with the local champions, to connect to the local protocol and the national protocol in order to improve the implementation. For instance, this is an example that we did here in Spain under the umbrella of the Food International with 3 associations, the main association around diabetic food, vascular surgeons, endocrinologists and diabetologists, and primary care, putting together, working together to implementing the recommendation for the international guideline under the umbrella of the Food International. Use this umbrella because this umbrella open a lot of doors. So it's not the same you are knocking one door and say, okay, I don't know, Jose Luis, like a podiatrist or BJ, like endocrinologist. If you are knocking the door and you say, okay, I'm a food national representative, is something different. So use this title, broadening of this to open the door to other associations and to work in the local play. Something that we need to avoid, the Star Wars, absolutely, because the splitting out, the fighting with something to another. No, we need the unity of many people around the world working in the same place. Why fighting? No, this is not a question of a war. It's a question of the peace. It's a question to working together. Perhaps we have different perspectives, we have different feelings, we have different interests. Why not? But we need to work in together because at the end, the most important thing is our patient. And of course, in the time that you are fighting with another person, in this time, probably one person is missing his leg, and this is very important. So the food can do a very good role, putting together in an integration and an international level. And I think it's another important role that the food should do about the unity around the world with different associations. Again, avoiding our main enemy, of course, ego, but ego is very common in medicine. That is something that is something inherent to some specialties. Avoiding opportunists, because sometimes the people say, okay, there is not a specialization in diabetic food. Okay, I'm the new expert in diabetic food for one day to other day. We need to remove the face mark of these people. This is very important, and avoiding the financial interest. Of course, this is another important. And again, improved patient outcomes should be our priority, because this is something that we can permit the variability in patient outcomes among the world. This is something that's, in my opinion, this is the main important problem. So last slide about what could be the solution of care. Of course, this is my perspective. Increase diabetic food awareness globally. You are doing very well. Society, patient, healthcare provider. Connecting with local organizations. This is the role of the food soldier, the role of the food national representative. Making easier and practical and useful the international recommendations. Some public people don't read the books, don't read the international guideline, don't read the information. Include the international standard in national and regional protocols. So change the protocol and include the international recommendation. Increasing the investigation in prevalence and health economic. This is something that is very few literature, and finding out that the space with everybody feel comfortable. This is absolutely very important. So thank you very much for your attention, friends.
Thank you, Dr. Jose Luis. I think our mission statement is ending lower limb amputations due to diabetes globally. And I think your slide, especially the local implementation, really talked about it. So I think it's very important that DFood International plays a very important role, as you said, not only in Spain, but all over the world, in trying to locally implement the policy.
Absolutely.
So
absolutely, I think that is one of the main role of every national representative of the Food International. So to implement at the local level, and I think it is very important role, and I can say that it should be mandatory for every national representative of the Food International trying to do something in your country. Otherwise, it's not possible to change the things.
So I think that's what DFood International should do and is doing at present. And I'm sure Dr. Abbas will continue that, involve the national representatives, regional council members as much as you can, So, message from, was there any questions to Jose Luis? Mariam?
No, thank
You are muted. Can't hear you.
Can you hear me now?
Yeah.
Thank you. Excellent two presentations on how to become a D-foot warrior and the way forward. Certainly, as the founder and past president, you have really enlightened the path forward with a lot of great recommendations that I'm sure we as a community will continue to work towards as we advance and raise awareness and fulfill the mission. So thank you so much.
Thank you, Mariam.
So, any questions for Jose Luis? Zahid, you're back with a good internet connection.
I don't know. Can you hear me now?
Yeah, we can hear you.
Yeah, the great lecture. Jose, thank you very much for your excellent talk. And you're talking about the awareness, creating awareness, and of course the national representative can do a lot of work in their country and as a region work together then in making this awareness to go forward globally. And talking about the cards, the info cards, we are here in Pakistan is using these info cards, and I recently recorded a whole document about this, recording 12 recordings on this, explaining in a local language about these cards. So these cards really help in understanding and making a quick decision, because the primary care and secondary physician do not have time to go into the details. And of course, this is a great one work you have done in your channel as well, apart from the others one. Thank you again, Jose.
Thank you,
Thank
Zahid.
you, big chat, happy.
Thank you, Zahid. This is different. Yesterday and today, Europe, we're doing it through a virtual platform. So I would like a 1-minute presentation by RX Events from India. RX Events, would you like to show your slides for 1 minute before we go on to the East-West? So RX Events has been our partner this time, and they have created a virtual platform. So all the panelists do not have that access, but any delegate, we have a lot of delegates from across the world who are watching this. So they have to first go through a lobby and then into the auditorium. Next slide. You can go through one by one, quickly, 1 minute.
Hi, good evening, everyone. This is Neerav from RX Events. As you can see the slides, we are totally into virtual platforms, and we are also into the physical conferences and all. And as you can obviously see that we have a totally dedicated team and all for this. And now, as the data already suggests that we are into more than 200 plus conferences, and also you can see that we have already streamed almost 12,000 plus live hours was for this. And we also take care of both the things like virtual also, physical also, and we do host the hybrid conferences as well. Now, these are some recent photographs that from the recently concluded RSSDI conference in Chennai. Now, this is something different because this is regarding a virtual platform. And these are all the snapshots of different virtual conferences that we have already done it. And you can see that there is a lot of more things that to be done, including the registration part in the starting, and the last is reports and insights. We take care of each and everything about it. As you can see that we do offer post-event services like registration reports and all, and we do focus on the financial matters, and so we do issue a financial report at the end.
Thank you, Nirav. Yeah, I think I'll move on now. This is your contact, right?
Yeah.
www.rxevents.co. So thank you, RX Events, for making the digital platform, and my IT team also worked very hard. So, Jose Luis, from what you said, I introduced a new concept called East meets the West. So we have Professor Hari Krishnan Nair, who's past midnight now in Malaysia. Sorry about that. So, and we have Dr. Laura from Barbados, who is representing Barbados, and they will interact with each other on. Professor Hari, you can ask the question.
Thanks, Vijay. I think since we have already seen what you call as Christian's lecture talking about diabetic foot warriors, Jose is one trying to get all the stakeholders in and all that. I think one of the things to ask Laura, how is it? I mean, how do you find, or what are the gaps in education when it comes to diabetic foot over in your area itself?
Okay, thank you for having me. The gaps, I think, are both the patient gaps in education as well as practitioner gaps. So with the local GPs, as Jose Luis quite rightly said, they're very integral in the whole multidisciplinary process. And what we have found here is that local GPs are not even aware of guidelines, and everyone does their individual thing. So as a result, patients have very varied outcomes, and it depends on what that practitioner does think. I remember in medical school, the surgeons, when we were being taught, told us that it was cheaper and easier to amputate than to worry with a diabetic foot ulcer. And unfortunately, a lot of those perceptions are still very much in tow right now. So I think that's one of the main things that we need to address, because those older surgeons who still have those beliefs are still there, and hence are very high rate of amputation. What do you think from your perspective?
Yeah, I think from Asia, I mean, we have around 4.7 billion people basically in the whole of Asia. And you find that, the staple food is all carbohydrates and all that. So most importantly is I would like to divide it like, number one is to the healthcare professionals itself. Like you look at even nursing schools and medical schools, most of them actually don't learn about diabetic foot ulcer management. It is just basic, straightforward. At the end of the day, you don't talk about how to manage the wound, how to close the wound, like how David has mentioned, and also to prevent the remission itself. So that is something we need to target. We have started some cases where we have got post basics for diabetic nurses after their diplomas or degrees and all that. 6 months where they become diabetic nurse educators, so that they do food assessments and all that. So that is already started, and they've also got one-stop centers in most of the hospitals. But in the periphery is going to be a problem, especially when they look at home nursing, they look at the community and all that. Doctors, the same thing. Basically, what happens is, if you look at Malaysia, we don't have podiatrists or even podiatric surgeons. So under the government sector, you don't have any of these, and that becomes a bit of a problem. The nurses take over this role. So I think that part of the education is important to actually empower them. And I think the fast track pathway together with the info cards have been quite helpful, but a lot more needs to be done. I mean, globally also basically, so that they find that most people are very interested in this when, that there's some kind of remuneration, some kind of appreciation, all that. To become a diabetic foot warrior is not easy. Most of us are already quite senior enough, so we're doing it for many years. So, not too bad, but younger generation a bit of problem. And then you have got the patients who also needs to be educated, because now you see when we look at patients and the caregivers, I think this is important because they are the one going to detect the diabetic foot first. I mean, the ulcer and all that, or even any changes in their foot, if they are empowered. That means your eyes won't see if the brain doesn't know. So it's no use, you see, because they need to come from the house to the clinic. And if the clinic doctors and everybody all are well-rounded, they know everything. But if the patient is not coming to you, there's no use unless you change it around and go down to the area. And I think in the islands, like in your place, also is quite a big problem, right? I think.
Yeah, one barrier I have for sure is the patient perception to doctors. So we have one main hospital in my country, and there is a perception that if you go there, they'll cut off your foot. So hence there's a delay to healing, there's a delay to presentation, because a lot of persons would stay home and use culturally acceptable treatments on their foot rather than going to get medical attention. So I think that is one big barrier because, I mean, we've had persons put everything from cayenne pepper and bleach on their foot, hoping that it will get better. And obviously those things are not going to have any good outcomes long term. Another thing is very high rates of peripheral vascular disease. Every single patient I have in clinic right now has peripheral vascular disease. And I mean, we have one vascular surgeon. So that, I think, and the education to know that we need to have more trained vascular surgeons is another part that needs to improve if we're to have better outcomes long term.
How is there any dictums like in terms of engaging and empowering the stakeholders for the prevention and treatment? I mean, anything?
I think that to empower stakeholders, we have to go at it from probably the economic benefit, because a lot of persons don't see the need for having diabetic foot be any part in their radar. But the amount of money that the government, because our healthcare system is publicly funded, but the amount of money that they're spending on dressings, which does not follow any evidence basis, is very increased. So I think that if we are to really engage the stakeholders and capture their interests, if we look and see, okay, if we follow evidence-based medicine, if we do proper foot screening in all of our patients and identify those at high risk earlier rather than waiting till later, I think that is likely to hopefully invoke some interest in these stakeholders, especially those from a political perspective who would have economics as an improved point.
Yeah, I think in this session also we have David, Jose, and Nicholas, who was like the top 10 people who have been publishing on diabetic foot. Congrats to all of y'all. You make us proud. And that is what you call is a great thing actually. But also the other thing is like, you know, in what we did is we also you work together with Ergo Medical and all that. So even in Malaysia, what we did is we chose about 50 clinics, about 30 of them from the general practitioners, GPs, 20 from the health clinics. And then we actually supplied them the fast track pathways, the info cards, and also the assessments for neurological assessment. And then they referred to my hospital. So we found that when you actually started that and start getting them on board, they actually started to detect more cases of diabetic peripheral neuropathy. So that's something just to add on here. And I think, I'm open to the group if there's anything else we can add on, because I think all of us in different areas have got different ways of managing. I was surprised in some places they have got a caravan. And then I think in India, basically, they have a bus which does a full foot assessment and the bus moves around everywhere. I think in Abbas's place, maybe he might have elephants with caravans going around in Dar. I'm not sure. I mean, there's a lot of things that can be done. Even I think in Spain, Jose, I remember lots of bicycles and all these things and all that. So maybe, you know, when they park their bicycle somewhere, they stop, they get a free assessment or a Doppler or something. You know, I'm just thinking out of the box. There's many ways of doing that. So I'm open to all. Maybe Mariam or someone wants to add in.
So the purpose of this meeting and this section was to make somebody from the East and somebody from the West interact on what Jose Luis said, local implementation. So Simon McConey could not join, so Laura took up her place. And, thank you, Laura, for, I think the main problem is we have to educate the GPs and the doctors, as you heard from Jose Luis. And that's a problem which you mentioned in your country. So I think that's a universal phenomenon. So I think we need to educate the doctors and the paramedical staff, nurses, and so on. They lack confidence, as you heard from Jose Luis. So we come to the last part, and Abbas, shall we play the Urgo video, which we didn't play yesterday? And
okay. Yeah, I think there was remaining 2 speakers.
Yeah, Urgo video, please.
Continues to investigate what is the impact of the use of sucrose octosulfate impregnated dressing in the treatment of patients with neuroischemic diabetic foot ulcer. So as a reminder, it's very important to take into account this is part of the standard of care. So the standard of care plus the use of this kind of dressing. And we were wondering about how or what is the possible benefit of the use of this dressing in the microcirculation of this patient. And according to this, you are the privileged to see in advance the result of our study that we will present on Sunday morning. And this is a brief summary about our study. As a rationally, I think that everybody knows the good outcome that the use of UrgoStar demonstrates in the Explorer study. It has been published in the Lancet publication. But after a while, we were wondering about it is something related with the improving of the microcirculation of this kind of patient. And especially because, as Marco explained it before, there are some changing in the ischemic profile of the patient. Some time ago, we were discussing about below the knee ischemia, after a while below the ankle ischemia, and now we are talking about a small disease ischemia. And for this reason, we need only to revascularize the patient. We need to improve the microcirculation. It is something that we were discussing some time ago. With this objective, we aimed to demonstrate if the patient microcirculation could be improved after the use of this sucrose octosulfate impregnated dressing. So we included basically the same profile of patient that we included in the Explorer study, with the same inclusion criteria, exclusion criteria. Remember that main important thing here, or most important thing here, is that was a neuroischemic patient. And we included the patient with the usual clinical assessment. We split out the patient in forefoot location and rear foot location, following the idea for Marco Meloni from Tor Vergata University. We performed the wound management inside of the standard of care, and we applying the sucrose octosulfate impregnated dressing at the local care at the dressing for the study. So the primary outcome was to measure what was the transcutaneous oxygen pressure after the ulcer healing or during the follow-up. The follow-up of the patient was 20 weeks, according with the follow-up period for the Explorer study. And we measured in two angiozones. For those patients who has the ulcer in the forefoot, in the reference location in the dorsal of the foot, and for those patients who has in the right foot, in the tibial posterior angiozone, as previously has been described for investigation in Italy as well in the Tor Vergata University. And we measured the TCPO2 at day 0, at the inclusion, and after 4 weeks, or when the patient healed. So as I mentioned it previously, the main outcome was to evaluate what's the microcirculation behavior after the treatment of this patient with this kind of dressing. This is the vascular baseline characteristics of our patient. The majority of them, remember, some of them underwent a revascularization, but others not. This is important to take into account. And you can see here what is the status concerning the ABA, TBA, and TCPO2. This is very interesting, related with the last presentation that we saw previously for Chris Manor from King's College, according with the difference that we had with different assessment in the vascular status. This is the wound baseline characteristics, the main duration of the ulcer, around 2.5 weeks, and with a wound surface area around 1.55. And this is the primary outcome. You can see here how is the trending of the microcirculation improving in the patient after the treating with the octosulfate sucrose dressing. You can see how after 4 weeks of treatment, we can see an increasing of the values of the TCPO2. And at the end of the wound closure, or when the ulcer has healed, you can see here how is significant difference with a good increasing of the values of the TCPO2 for all the sample. We split out for those patients who has a impaired microcirculation. And according with the previous study from Kalani, we define impaired microcirculation for those patients who has below 30 millimeters of mercury. And you can see how even when the patient has below 30 millimeters of mercury, the improvement of the microcirculation was the same when the ulcer was healing. You can see here, and with the more or less the same trending. This is, in our opinion, the most important thing, because this is the most difficult patient to treat. This is the trending of the TCPO2 values among or within the study, and you can see how the TCPO2 is increasing with statistical significance after the treating of the patient. Concerning the ulcer location, and is related with the previous presentation that Marcos showed us, is we split it out the patient those who has the ulcer located on the forefoot and those who has the ulcer located on the red foot, and you can see how, of course, we observe a better trending in passing with forefoot location, but as well in passing with red foot location, especially after 4 weeks of application. I can say that one is, important limitation of our study is the small sample that is going to reduce it. So at the end, we have a very small sample of passing with red foot location, and for this reason, probably there is not a significant difference after 12 weeks or even in the bone closure. But the trending is went well in both groups, regardless the location. So we demonstrate in a pilot study that the use of this kind of dressing can improve the microcirculation of the patient, and this could be one of the reasons because there is very useful in passing with neuroischemic or with impaired ischemia related with diabetic foot. So as a conclusion, we can say that the local treatment with TLC nose dressing, sucralfate impregnated dresses, improved microcirculation in passing with diabetic foot, regardless of vascular status at the baseline. So thank you very much for your attention.
Jose Luis, since you're here, in India now we have Urgo Clean AG, Urgo Start. So the International Working Group on Diabetic Foot is sort of recommending its usage. So what is your point on the various moist wound?
Sorry, I missed you the last statement.
What is your view on the various wound dressings available from Urgo, like Urgo Clean AG and Urgo Start?
Yeah, so definitely. So especially because, as you say, this dressing was included in the last recommendation, the last guideline, especially for neuroischemic diabetic foot patient. So limitation and barrier, of course, in many countries there is not available this technology in this dressing, and it's something that we need to ask, especially because in other disease, doctor and patient are mobilizing for asking for some specific drugs. For instance, imagine that in some country there is not insulin and there is not statins, so it's not probably the same, but at the end, improving the healing process in this kind of patient is saving legs and saving life, and I think it's very important. So something that we need to ask for our politicians is to invest more money in something that demonstrates that is working, and putting the money in the right way, because sometimes they are investing in something that is not demonstrate that is working. This is my opinion.
Yeah, agreed, 100%. Abbas, would you like to give the word of thanks?
Okay.
I can see Harry is very sleepy.
Yeah, Harry is very late, so we need to tell him before he goes. But I would like to thank all the speakers, starting from Christine from Belgium, David Armstrong from USA, Professor George from Spain, Professor Harry from Malaysia, our board member, and Dr. Laura from Caribbean. All the speakers took time from their busy schedule and accepted the invitation to talk on all these important issues. Thank you very much from our left ventricle. I would like to thank the board members, role of DFoot International, Vijay, Nicholas, Linda, Harry, Mariam, and all the regional chairs and councillors. Thank you very much for doing the job in all the 7 regions. Special thanks goes to the core team and the IT service, which is provided by Vijay Secretariat Personnel Office, Sevil Kumar, and the Secretary, Marilyn. Big thank to all of you. Finally, I should like to thank all the delegates, because without them, without delegates, no webinars were possible. So a very big thank you to all of you. Thank you very much. Yes, Vijay.
Linda, can you switch on your camera for a minute? Linda Pedrosa. Yeah. So I'd like to thank everybody for taking part, the board members, the regional chairs like Maimuna is here. So DFOOT is working very hard to implement what Jose Luis said, regional, the local implementation. And I think the board and the regional council, the national representative, have to work a little harder. And the board will definitely be in touch with the national representatives, because you're paying 80 euro every year to become a full member. So 80 euro is a big amount, and you get access to the General Assembly and so on. But I think you have a primary responsibility of improving the foot care and prevent amputations in your region. So I think the regional chairs and national representatives have a very important role to play. I would like to thank all the board members and regional council members for this Diabetic Foot Awareness Week. Tomorrow is the last day in the Western Pacific region. And with that, we conclude. And I think from Jose Luis's period, from 2020, we have had every year, 2020, 2021, 2022. This is the third year we're doing the Foot Awareness Week. It was decided when Jose Luis was the president and I was the president-elect. So I think, thank you, Jose Luis, for starting this initiative. And the info cards has also been translated into many languages, in my country, into 2 languages, Tamil and Hindi. So I think we will translate it. We're looking forward to translating and implementing the 2023 guidelines. So once it's out, we will make sure by the time Abbas will be the president, he will take up the implementation, translation and implementation of the 2023 guidelines. So I'd like to thank all of you for taking part, and thank you, Harry, for staying awake, and all your all your participants from the Western Pacific region. Thank you, everybody, and take care. Bye.
Thank you. Take care.